Allopathic Medicines, Part 15. Several organizations have developed grading systems for assessing the quality of evidence. For example, in 1989, the U.S. Preventive Services Task Force, USPSTF, put forth the following system. Level 1: Evidence obtained from at least one property design, randomized controlled trial. Level 2: 1. Evidence obtained from well designed controlled trials without randomization. Level 2: Evidence obtained from well designed cohort studies or case control studies, preferably from more than one center or research group. Level 2: Evidence obtained from multiple time series designs or without the intervention, dramatic results in uncontrolled trials might also be regarded as this type of evidence. Level 3: Opinions of respected authorities based on clinical experiences, descriptive studies, or reports of expert committees. Another example are the Oxford CEBM levels of evidence published by the Center for Evidence Based Medicines. First released in September 2000, the levels of evidence provide a way to rank evidence for claims about prognosis, diagnosis, treatment benefits, treatment harms, screening, which most grading schemes do not address. The original CEBM levels were evidence based on call to make the process of finding evidence feasible and results explicit. In 2011, an international team redesigned the Oxford CEBM levels to make them more understandable and to take into account recent developments in evidence ranking schemes. The Oxford CEBM levels of evidence have been used by patients, clinicians, as well as by experts to develop clinical guidelines such as recommendations for optimal use of phototherapy and topical therapy of the psoriasis, and guidelines for the use of BCLC staging system for diagnosing and monitoring hepat- hepatocellular carcinoma in Canada. In 2000, a system was developed by Grading of Recommendations Assessment, Development and Evaluation Grade Working Group. The grade system takes into account more dimensions than just quality of the medical research. It requires users who are performing an assessment of the quality of evidence, usually as part of the systematic review, to consider the impact of different factors on their confidence in results. Authors of grade tables assign one of the four levels to evaluate the quality of evidence on the basis of their confidence that the observed fact numeric value is close to the true effect. The confidence value is based on judgments assigned in five different domains in a structured manner. The grade working group defines quality of the evidence and strength of recommendations based on the quality as two different concepts that are commonly confused with each other. Systematic reviews may include randomized controlled trials that have low risk of bias or observational studies that have high risk of bias. In case of randomization, controlled trials, the quality of evidence is high but can be downgraded in five different domains. Risk of bias, a judgment made on the bias on the basis of the chance that bias in included studies has influenced the estimate of effect.